Hi everyone. Our last video left off on slide number 7. So I'm just going to pick up right here on slide number 8 and we're keep going through this PowerPoint. Here at the cervical region, remember this is up within your neck, those 7 pretty delicate cervical vertebrae. The joints are appropriately named by the bones. So you've got atlanto-occipital joint. So remember, your atlas is your very top cervical vertebrae. So your C1, and then occipital would be a portion of your skull. So that joint between your atlas and occipital is the joint between your skull and cervical vertebrae number 1. This one is important because it allows flexion and extension. So from a standpoint of gesturing, this allows us to shake our head yes, going through a flexion and extension movement. Atlantoaxial joint, this is appropriately named because the 2 bones involved are your atlas, cervical vertebrae number 1, and your axis, cervical vertebrae number 2. So when you put these 2 bones together, we call this your atlantoaxial joint. This is unique because this is the most mobile joint of any 2 vertebrae. This joint allows us to shake our head no, like you're going to disagree with something. This is a trochoid or pivot type joint, which also makes it a little unique. And if you stop and think about it, or you try this, you can turn your head comfortably to the right or to the left much further than, say, you could rotate at the waist, being at the lumbar region. So that is why we have the most mobile joint of any 2 vertebrae here at your atlantoaxial joint. If we get out of the cervical region, move on to the thoracic region, this is a little better image because it demonstrates how you've got all the ribs. You can see how the ribs attach posteriorly at the point of the vertebrae, and that is what makes them a thoracic vertebrae. Just at a glance, if you check out a skeleton, notice that if it has a rib attached to it, that is going to be a thoracic vertebrae. And it's a pretty easy distinction because everything above the thoracic region is cervical, everything below, immediately below, is in the lumbar region. So when we talk ribs, we have 7 pairs of true ribs. A true rib attaches directly to the sternum. You can see how rib number 1 comes across and it attaches there to the sternum. The first 7 do that. Now, once we get down inferiorly, we have 5 pairs of false ribs. That means that they indirectly attach to the sternum. So if we look down here at number, let's just say 8, 9, and 10, see how number 10 grows into number 9. Number 9 grows into the cartilage of number 8, which grows into the cartilage of number 7, and then attaches to the sternum. By definition, that's considered a false rib. And then down at the bottom, you've got number 11 and 12. Notice these ribs actually do not attach anteriorly at all. If you take a deep breath in, you can palpate on your right and left sides and you can feel the tips of these ribs on your thoracic cavity, and that's actually a common bony landmark that we look for when we're placing electrodes for an EKG. The thoracic region is reinforced by the rib. So I kind of like this view over here. You've got a thoracic vertebrae, but then look at the rib, how the rib wraps around and then it's going to attach to the sternum anteriorly. That in and of itself adds a lot of structural integrity to this region. As a result, your thoracic region is very, very stable. If an individual were going to have a injury to the vertebral column, a lot of times it's going to be above this region and the cervical region, or below it at the lumbar region. And one explanation is when you have the ribs attached to the thoracic region, it's really, really stable. We have some movement here, but it's not a lot of movement. If many of you are CPR certified, you know that you can collapse and then there's a spring recoil to the ribs. So there is some thoracic motion. If we break it up into planes, We say your thoracic cavity can move in a sagittal plane and a frontal plane. I think our textbook did a pretty good job here. You can see how this water spigot, this frost-free hydrant here, you grab the handle and you move it out and then back in. Well, when we compare that to your rib cage, you know, here's your backbone, here's your sternum. When we take a deep breath in and then exhale back out, your rib cage moves away from your backbone and then towards your backbone. Anything in front or behind you is in a sagittal plane. So your thoracic motion does occur in a sagittal plane. Now this picture demonstrates our ability to lift our ribs and lower them back down, just like the handle on a bucket. We can lift this up and it lowers back down. So you can actually palpate your ribs on your right and left side. Take a deep breath in and you feel your ribs rise up out laterally, and then when you exhale, they fall back into place laterally. Well, any movement to your right or left is in the frontal plane. So when we talk about thoracic motion, the motion occurs both in the sagittal plane and frontal plane with every breath that we take. This thoracic region is manipulated by pressure changes. So as the pressure within your thoracic cavity changes, it either pulls air in or forces air out. So for inhalation, when we pull air in, our diaphragm contracts and the pressure interiorly drops, and as a result, from the environment, air rushes in. So that's how we take a deep breath. When we exhale, your diaphragm relaxes, and the diaphragm actually has some elastic recoil and some ability to go up into the thoracic cavity, and that in and of itself, during quiet breathing, can force air out. So the mechanics of breathing at rest are pretty much driven dominantly by the diaphragm muscle. Here in a few more slides, we'll look at some accessory muscles, meaning if you're running sprints and really bringing air in and forcing it back out at an accelerated rate, we're going to call upon more muscles than just the diaphragm. But a real quick and easy rule of thumb to resort back to with this concept: if a muscle expands the rib cage, it's going to be an inhalation muscle, and if a muscle collapses the rib cage, it's going to be an exhalation muscle. So we will wrap up here, and that will leave me plenty of time for the next video.